All right, good morning. Red flag back pain is our topic today. Ricky, you got everything what you need there? Okay. I used to hear people talk about red flag back pain kind of thing. I said, what the heck is, well, yeah, cancer, okay, I got it kind of thing. We used to do occupational medicine at our hospital. We used to take care of the fire departments, police departments, school districts, a lot of the employers around. And I used to be the doctor who would follow up all of the back pain patients. Do any of you do any occupational medicine kind of things where you are, for the hospital or anything like that? You're the doctor for the hospital, probably for the first visit, but they send them off to other people. Well, I got to see for a couple of years what it was like to treat back pain, and there's thousands of articles written on it. It's really a major issue with regards to disability, costs, those kinds of things. But you could distill all of the literature on back pain down to probably about 10 or 15 kind of principles. The vast majority of musculoskeletal back pain, hurt my back lifting a box, those kinds of things, will get better no matter what you do. Just don't stay in the way of the curing process. The statistics are 85% are better within 6 weeks. Then there's a small percentage that goes on and nagging kind of thing. Some of it's related to occupational issues with regards to disability and those kinds of things, but most of it isn't. Most of the people are well-intended and they just tweak their back at work kind of thing. God forbid you tweak it not at work, then you really have a problem in terms of your disability issues. But the fact is that pain pills are helpful. Muscle relaxants are basically sedatives, and they don't relax anything particularly, and it's going to get better. Physical therapy is basically shake and bake, expensive shake and bake. You'll be better no matter whether you do it or not. A lot of people in the occupational medicine industry have a lot of vested interest in physical therapy, but it's really difficult to show that it makes a compelling difference whatsoever. It is more caring, it is more touching, it is more visits, it's those kinds of things which make you think that this must be good. And when some people get physical therapy and the others don't, the ones who don't say, how come I'm not getting physical therapy? Because they actually believe it matters, and it really doesn't. But that's the long and short of it. But I've seen recently some cases of red flag back pain, which got missed by doctors just because it is so easy to miss these cases, some more so than others. One of the other things about musculoskeletal routine back is the role of x-rays. About 6 or 7 years ago, this agency called the Agency for Healthcare Research and Quality, AHRQ, started doing guidelines for the treatment of medical conditions. And one of the first ones they did was the treatment of back pain. And they recommended in those guidelines, this is federal, they recommended in those back pain guidelines, no x-rays of the back for 6 weeks. No x-rays for 6 weeks, musculoskeletal lifting a box kind of back pain. Because one of the things that's very clear is you'll never really necessarily make the anatomic diagnosis of why this person has back pain. Yeah, they might have some sciatica too, but in terms of the musculoskeletal reason that they have it, you just tweak something down there kind of thing. X-rays are not going to change the therapy. X-rays are an issue. Lumbar spine x-rays are 3% of the x-rays taken in the United States, 15% of the radiation. They're disproportionately juicing you up, particularly when you go for the Scotty dog's necks, looking for the spondylolysis and spondylolisthesis kind of thing. It doubles the amount of radiation. So 3% of the x-rays, 15% of the radiation, which can be doubled when you do the oblique views. We did last year a talk on medical radiation. Medical radiation is really about CAT scans. By far, the most radiation is given out by those things. But lumbar back x-rays are disproportionately heavy, and they're down there where the gonads are, so that there is some issues, potentially. No, not a big deal. Don't want to overstate it. But they said don't do x-rays for 6 weeks. And the Orthopedic Society went nuts when it said, what do you mean, don't do x-rays for 6 weeks in these cases? And they got so upset over the fact that the government had generated guidelines, literature-based kind of thing. They had a committee of all these experts these guidelines that they basically shut down this agency. And this agency, which was promulgated on making guidelines, was not allowed to make any further guidelines. They could gather guidelines generated by other people and show you here's all the back pain guidelines and here's all the irritable bowel guidelines, and so they became a clearinghouse for guidelines, but it shut them down in terms of trying to do this in an objective, dispassionate manner. The goal of these x-rays in back pain is to try to find something that will change the therapy. And most of those turned out to be under this umbrella of red flag back pain. They came up with the phrase that agency did, and we have some sense of it, but I think that the sense of red flag back pain is broader than we generally think. As an example, they said if somebody comes in with a back pain kind of thing and they're under the age of 20, you can take an x-ray the first visit. New onset of back pain in somebody under the age of 20. I said, what the heck can that be? What can a 20-year-old have in the way of back pain? Well, the fact of the matter is according to the people who made up this list, they have, their back pain is not the same as I hurt my back lifting a box. Their back pain is posterior element back pain. It is the pain associated with spondylolysis, spondylolisthesis, and it is seen in these young athletes, cheerleaders, weightlifters, football players, anybody who can hyperextend their back repetitively. And those people are the ones who get these little cracks in the Scotty dog's necks, which is what you see best when you do those lateral lumbar spine x-rays. And the issue then is, if they have developed one of these cracks, are they prone to the, now that it's cracked, are they prone to this shifting of the vertebrae one on the top of the other, L5 on S1 generally, in terms of this spondylolisthesis business? And if so, then they should be basically said, whatever you're doing, if you're a football player or you're a basketball player or you're a gymnast, as a young person, you ought not be doing that because you are at risk of this progression. So the idea there is they have posterior element back pain. Posterior element back pain is made worse on extension. Most people, when they have back pain, it's worse when they flex. This is just the opposite, worse when they extend. They have really tight hamstrings, they have tight lumbar spines, and so it's difficult for them to flex forward in terms of their ability to do it, but pain is extension, which is atypical from what we would normally see. So the x-rays may show these pars defects and this issue about slippage, and so the goal here is early identification to avoid provocation to worsening of this condition and future slippage. And then the other extreme is people who have 1 foot in the grave, people over the age of 55. Those of you over 55, they're concerned about 2 things, cancer and osteoporosis and osteoporotic back fractures. Now, that's certainly less common in men, but there's a really pretty impressive primary care literature that says women in particular who are identified to have osteoporotic fractures are rarely identified in terms of, hey, well, we can treat you for osteoporosis and send them to their family doctor. They're talking about women who break their, fracture their wrists on falls and they've got these, bones that barely show up on x-ray. Or you're doing a chest x-ray and you're doing an AP and a lateral chest x-ray and a lateral, you see all of these little compressed vertebrae in this older person. They said, listen, this is obviously clinical manifestations of osteoporosis. There is treatment for osteoporosis. And so the literature is saying there's this disconnect between identifying these fractures and referring these people for care. So maybe that would be something that you might amp up in terms of your practice if you, in fact, identify somebody who's got what appears to be an osteoporotic fracture in the age range. So 55 and older, you're allowed to get an x-ray on the first visit, but that's it. Looking for cancer or osteoporosis. Obviously, you're allowed to get an x-ray if you have one of the whether is some kind of violent injury that could have caused this back problem, like you were in a car accident or you had a seatbelt on and you went right forward and you kind of crushed your vertebrae in the process of doing that. But you don't have to fall very far. I mean, we've all seen older people who maybe even fall off a chair, land on their butt. Maybe they could have. So you have to kind of use some judgment. But it's enough force to break a vertebrae in a certain person. That would be a person. You're allowed to x-ray those based on the history of the force that occurred. Back pain that is constant or getting worse. Constant back pain is generally not musculoskeletal back pain. Musculoskeletal back pain is worse when I do that, it's better when I do this kind of thing. But if it's constant, constant is supposed to reflect the back pain of an infection or the back pain of cancer as a kind of an alerting. Yeah, some people are going to have back pain, and it's always there. But the idea of it can be made worse or it can be made better by certain kinds of movements is kind of one of the differentiators. So they want you to kind of be aware of people who have constant back pain, because that's not the characteristic of the typical musculoskeletal kind of back pain. They talk about spinal stenosis as another cause of constant back pain. Spinal stenosis is generally older people. They talk about the diameter of the spinal canal is genetically determined. So some people are lucky to have big ones and some people are unlucky to have small ones. And those small ones can be compromised by a variety of processes, like they're talking about degenerative changes, the spurred vertebrae, disc narrowing, arthritis, spinal misalignment, so the canal is one above the other is kind of getting kinked, disc herniation, curvature of the spine in the elderly. And the one that has caused people talk about the most is hypertrophy of the ligamentum flavum, which kind of makes the spinal column pressing on the cord and those things, and that is consistent also with this idea of having pain all the time. One of the characteristics of spinal stenosis is pain with walking. The pain in the back and the pain going down the legs gets worse when they walk, gets better when they stop walking, gets worse when they walk. Sounds like a vascular problem. Sounds like a compromise of the circulation. This is a neurologic, it's called neurogenic intermittent claudication. Neurogenic intermittent claudication. It's not vascular, it's based on these nerves being compromised as people kind of walk. In these cases of spinal stenosis, the older people, they basically have pain that is made worse by lying flat. They have pain that is made worse by hyperextending, which is, again, unusual for back pain. And they feel better when they get themselves sit into a chair or get into a ball where they can flex forward, because flexing forward increases some of the space in the spine area for these folks. Sudden onset back pain is also one of the red flags. Sudden onset back pain, the list is aortic aneurysm is on that list, as is some kind of pathologic fracture that has triggered this thing. Aneurysms they talk about here in abstract number 5. Abdominal aneurysms are 8 times more common among siblings of aneurysm patients. So not only are thoracic aneurysms running in families, that was 20%. Here is this relationship with abdominal aortic aneurysms running in families again. So that should be one of the questions that you may consider asking. Pain at rest and nocturnal pain are consistent with aneurysms. Pain at rest and nocturnal. So this thing gets bigger, 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 generating some pain kind of thing. Another red flag is pain in the thoracic spine, because the thoracic spine is not supposed to be the source of much in the way of musculoskeletal lifting, bending kind of back pain, because the thoracic spine doesn't move very much. So when you bend over, you're bending the lumbar spine, you're moving your neck. So the neck and the lumbar areas move a lot and are more subjected to mechanical musculoskeletal kind of pain. Thoracic is not. And thoracic is also the home of some of the more nasty kinds of things like infections as well, which we'll get into in a second. So the upper back is relatively protected musculoskeletally and mechanically from strains and sprains, and is therefore kind of makes you suspicious if that's what they're talking about. Pain in the upper back suggests an increased likelihood of more sinister conditions like cancer and infections. Spinal epidural abscesses tend to be thoracolumbar spinal epidural abscesses. How many of you have seen a spinal epidural abscess? Anybody? Wow, well, that's at least half the people in the room. This is the source of multiple lawsuits against doctors because the diagnosis is delayed. In the process of delay, there's more and more neurologic compromise that they generate, and the dollar signs keep on going up. Obviously, if you have a history of recent cancer or past cancer, that's considered a red flag. You're allowed to kind of image those people at the first visit as well to identify those cases. The big three that go to the big three cancers that go to the back are lung, breast, and prostate. Lung, breast, and prostate, they're pretty common cancers. Multiple myeloma, less common, and lymphoma, less common, are also, would round out the big five that go to back, lung, breast, and prostate. So that would be something to consider. Back pain in steroid-taking patients is considered to be a red flag. Why? Osteoporosis or infection, increasing the risk thereof. And there clearly is more infections in the back than there used to be because more and more people are having surgery where they're having stuff put into their back. And these things serve as nituses for infection. There's also this issue about epidural injections are more associated with risk of back pain, and there are lots of those going on now. So back pain in the drug abuser or and/or HIV patient is the easy to miss ones. They may be perceived as drug seeking. You hear again, everybody, the eyes roll, oh geez, Mr. So-and-so is here with the back pain again. They know he's a drug, you know, they got this needle tracks or formerly kind of thing. So does he get a big warm welcome when he comes back to the emergency department? Nice to see you again kind of thing. No, he's put in the category of the ER abusers. And so there's basically the idea to shine them on kind of thing. Try to deal with it as efficiently, as quickly as you can to get them on the way. And then you miss the fact that this drug abuser, yes, he's shooting drugs, has gotten an infection that has settled into his disc space, and now which is now moved to the epidural space and is now moving up and down. And those pains that he's having are real and worse, and maybe associated with some neurologic compromise that's going to develop. And you will turn that drug abuser into a very wealthy, paralyzed drug abuser, because basically by the time the things diagnoses are made, the neurologic complications are pretty obvious. And one of the red flags in terms of all the back pain patients, unless it's really, really obvious, is that you have to note the vital signs of the patient. If a person has a temperature, a fever, we all have temperatures. If we have a fever over, and defined as 100.4 in a back pain person, you basically have to trace these things down. Is this an infection going on in the back? And circle that number to make it clear that you've considered this diagnosis in these patients. A SED rate is considered to be a good screening test for these cases. I mean, generally a SED rate, we avoid that like the plague, but it is generally elevated. So if you were to do a SED rate and it was negative, that would be kind of helpful. If you've noted the temperature, that would be helpful in these cases because back infections are getting more frequent rather than less frequent. They talk about the age range for these. The age range for spinal epidural abscess, the highest age range is 60 to 70. 60 to 70. But the ones that we tend to miss are the younger people, generally in the environment of the drug abusing people. You know, my friend Greg Henry would basically talks about people who abuse the emergency department, and he uses this analogy of the McDonald's, going to the McDonald's. And McDonald's never says, what, you hungry again? Weren't you here last week? You want to eat again? Or the asthma patient comes in who's recurrently there, and he basically calls them oxygen abusers. You know, you're oxygen seekers, basically, those kinds of things. It's so easy to kind of set up an environment where we would miss these cases because we really don't want to deal with them. They talk about these infections being either anterior or posterior in terms of spinal epidural, anterior, posterior. The anterior ones begin with disc-based infections. Disc-based infections migrate posteriorly, cause this abscess. That's the minority. That's 20% of them. They get this vertebral osteomyelitis, disc-based infections, and away you go. The posterior ones are the more common ones. 80% of the cases are posterior. And where do they come from, those infections? Those come from distant sites. Cellulitis, a dental infection, pharyngitis, pneumonia, any of those basically can seed the posterior by hematogenic spread. The most common source of these is staph, so they tend to be skin-based infections. And so, yeah, that's a tip-off. Have you had a recent, some kind of infection that is causing you, and that may be linked to your back pain? Good thing to ask, kind of thing, maybe. Low-grade fever. The other thing that is one of the tip-offs in these cases is that if you start going down their back and feeling over each vertebrae, there may be one vertebrae that is obviously tender. Focal tenderness is one of the signs of infection in these cases. And start high, because these things tend to be in the thoracic rather than in the lumbar vertebrae. Pain unrelieved by rest is the general view of infections. Pain unrelieved by rest kind of makes you think of infections. So those are kinds of things to try to avoid missing these cases. And they talk about another red flag is back pain in the person who is generally unwell or feverish. Well, you know, okay, we'll give you that. That could be cancer, it could be an infection. They point out in this thing, pneumonia, cellulitis, UTIs are being the most common source of infections seeding the back. And the predisposers to those infections are HIV, diabetes, corticosteroids, and all of the things that you know, organ donors, organ transplants. They're on immunosuppressive therapy. So the idea is to kind of broaden your awareness of things that will cause potentially nasty back pain. Back pain with significant weight loss, we always think of that as cancer, but there are a couple of other things. HIV is a cause, and there are a number of the inflammatory back conditions like spinal rheumatoid conditions that are basically associated with being unwell and losing weight, which we'll talk about in a second. Back pain associated with greater difficulty bending forwards. Bending forwards was the kids with the posterior element problems. And another group of people who can't bend forward very well is this ankylosing spondylitis. These are the people who are generally 40 years old. They get, this is a genetically predisposed inflammation of the sacroiliac joints, moves up the spine. They can get the spine to be kind of rigid. They talk about bamboo spines when it's kind of far advanced situation, but it begins in the sacroiliac joints. And then they talk about another red flag would be the nerve-related problems. You're allowed to have pain going down your back, down to your knees. You're not allowed to have pain going much further than that. If you have pain going down to your legs, motor weakness, sensory deficits, then you know obviously you've got a nerve being compressed, and the issue is, will that resolve on its own, or will that need some kind of surgery? Most of them will resolve on their own. Just because you have some element of your ankle or your knee reflexes, maybe not quite as strong on one side as the other, doesn't necessarily mean that that requires surgery. Most of them resolve on their own, but clearly they need to be followed. They're not something that you're going to be dealing with. And then, and I think the last one is this cauda equina business. Anybody ever seen one of those? Yeah, you've seen everything here. So this is the spine ending at L1, L2, and then you have down in the spinal column all of these nerves running down like the horse tail. Going to be a good day out there for rain, I think. And so the fact of the matter is that all of a sudden these nerves can be compressed by some kind of pathologic process, either an osteoporotic fracture, a tumor which is grown large enough to compress. Bleeding into a tumor would be an opportunity for sudden onset of the compression of these things, and the manifestation of compression of the spinal nerves there, spinal roots, is bladder gets distended. You might have some overflow. Rectal tone goes down. One of the papers, there have been lots of papers that deal about doctors' ability to recognize abnormal rectal tone. We're not very good at it. We need to practice rectal tone more so that our frame of reference is better. But in any case, that's one of the things. Sudden onset of severe pain may be associated with these neurologic problems. It is considered to be a neurologic emergency. Let your fingers do the walking. They get steroids, they get operations, they get identification of what is the pathologic process that is pressing on the spinal roots that are down low there, and then that's it kind of thing. Persistent or worsening sciatica. So somebody's had some problem, the sciatica is getting worse. Those people are worthy of imaging. They're worthy of obviously getting referred. Back pain with obvious structural deformity. Obvious structural deformity. So you're feeling down this person's back and there's a little step off. Could be tumor, that's rare. Spondylolisthesis, the shifting of one vertebrae on another, would be a situation where that would be something worthy of early imaging. Back pain, so we got that. And debilitating back pain that is not resolved in 4 to 6 weeks. Those people can have more things done to them. But the fact is I think that we, in the emergency department, probably have a fairly low threshold for obtaining back x-rays in young people, especially if you come by ambulance and make a big fuss about it. They're more likely to get x-rays. I would basically tell people there's a lot of radiation to your gonads associated with this x-ray. We honestly don't think, based on the history that you've given us and all of these other negative things, that there's anything serious going on here. Let's get you home, let's get you some rest for a couple of days, then start your normal activities as best as possible. The value of back x-rays is to irradiate the gonads and mutate this subset of the population off the planet. It's a long-term goal. It's not going to help this person particularly, but it's, ultimately it will rid the population of these weak people's backs. This is one of the few reasons not to be an orthopedist, as best I can determine, back pain. All right, anything else you want to talk about at all here?